Dr. Jagath, are you there?
Yes, I can hear you.
Right. Good evening, everybody. We are going to start the first GP Cafe session for 2025 tenor, and I'm Dr. Asita. I'm the Spice Road Country Chair of Young Doctors Movement of Wonka. And it is my pleasure to invite Dr. Jagath Pelandagama, one of our eminent GP who has achieved MCGP after his MBBS, and he's now practicing as a part-time GP at Kalapaluava, Rajagiriya. He's more than interested in having his experience sharing with all of us. And I welcome Dr. Jagath Pelandagama to share his experience. Today's topic is when things are left behind. Dr. Jagath will have the session, and afterwards, at about 5 minutes, we can have some questions and answer session if the audience are happy. So I welcome all of you to join our session today. Jagath, over to you.
Yes, can you hear me, Asita?
Yes, we can hear you and we can see your slides.
Okay, then shall I start? Then,
Yes, please go
okay,
ahead.
thank you very much. Thank you. And good evening to everyone. Today gathered to listen this presentation. And actually, this presentation is based on my MCGP, MCGP portfolio in the reflective component. So it has been happened in 3 years ago. Actually, it's a two scenario. So we'll try to go through. Mm. This introduction. So this is Mrs. F.A. mean we are not telling the names in the audience. So she is now 41 years. That time she was 38 years old lady. And she's from Rajagiri. Actually, she's from my neighborhood. Okay, she's married and mother of two children. Two children mean there's some speciality about that elder child. Of her elder child is born with some congenital brain disorders. So not a good disabled child, and from the Clerici Hospital managed as a disabled child and with some cerebral palsy. So our patient is always put a time and occupy with this child's works. And another one, next child, second child is a young daughter, and she is doing well. And they are from my neighboring family because I more than doctor-patient relationship, we are neighbors. So her history in brief, she has been suffering from menorrhagia and dysmenorrhea for a long time. I mean, after first childbirth, she was continuously suffering from this problem. And I think you can hear me. Hello.
Yes.
All right.
Yes,
Thank
we
you.
can hear you,
Yeah.
Dr.
Thank you
Jagath.
very much. And this has been, I think, she's suffering from this problem after the first childbirth, and then and there she come to taking treatment and advice from me. It was really suffering her life. I mean, during the menstruation times, she's very pain and passing blood with clots, and but she's unable to go to for proper medical advice because of she have to occupy with the elder child. So not only myself, the several general practitioners, including VOGs, treat her in average. If you take the summary, some mefenamic acid, tranexamic acid, then and they are treated, but there's no regular follow-up and in one place like one medical clinic or no, sorry, the gynecology clinic because of that elder child problem. See, time is all occupied with child and not able to go to the proper gynecological care. Then uh, some sometimes we are checking her full blood count, and I observed her hemoglobin level was getting low, but still she is not able to go for a proper treatment. And then the symptoms of anemia appear despite the hematinics iron therapy, because continuously not able to tolerate it, the problem. And she's shortness of breath and lethargic, and she's no more managed with her day-to-day activities. So then she thought to go for proper gynecological treatment. Then I refer her to the nearest close gynae hospital uh, for further care. I think this is her, yes, this is her clinic records. I shared her identity here. And the interesting thing here is, look at the, I think size are much clear enough to see you hemoglobin level. Just concentrate on the investigation part, WBC, then hemoglobin 5.4, and three blood has been transfused, I think accels, and it has top up to 7.9. Then after some time, uh, the gynecological teams usually decide to do the vaginal hysterectomy. So then and there she come to me and with her husband, and take some advice and talk, discuss with what is happening. So she hesitated to do this vaginal hysterectomy because she needs some child. She not completed her family. So she very hesitate to take this decision even with the clinic management, clinic follow-up. So finally she agreed to do because she not able to tolerate the suffering. So uh, this is the again the preoperative hemoglobin level was, it was 4.4, 5.4. So I mentioned it because this is the mm, level of preoperative hemoglobin, because that's why she got the symptoms and of lethargy and shortness of breath. And they have done the vaginal hysterectomy. All the intraoperative, postoperative period was no complication, and uh, they have routinely discharged the patient to the home. So husband came, and that day, doctor, we came from hospital, and many thanks for you to push them up to do this surgery. Uh, then after, it was the, I think, post surgical day 3 or second day she has discharged from the hospital, and the next day it was the post operative day 4. Post operative day 4, uh, her husband came to my clinic with a complaint. Dr. Asita, up to now is clear. You want to recap the things?
No, you can go
Ah,
ahead.
right. This is a simply a 41, 38-year-old lady has done vaginal hysterectomy with some family circumstances with a disabled child, and she's from different cultural background and my neighbor, and she has done vaginal hysterectomy. And the fourth post-operative day, her husband came to my clinic. For clinic mean I those days I used to practice in my home, so they have very easy access to me. They come and discuss with me. He complained about his wife complaining about constipation and features of dysuria with low abdominal pain. So then after I quickly asked, is there any vaginal bleeding or discharge? He, he says no, there's no such complaint. And he requests me to come, please doctor, come. Can you have a visit, because he is not able to come. mm, to the my office. So then, with her husband, I went to her home and uh, got some information about history, whether it is afebrile or not, and actually she was afebrile. And the other system examination, blood pressure was normal, pulse beat tachycardia. I think it has relevant with the her pain, dysuria, and other things. She was not pale actually. Other system also normal. I mean respiratory, everything normal. So, uh, that then in my mind, uh, I was thinking what may be the reason. So I, for the audience, I here just stop and can you contribute what could be the reasons for this her complaint? I mean, dysuria, constipation, low abdominal pain, and discomfort like of a 41-year-old lady to sorry 38-year-old lady after post-operative fourth day. So can you uh, just tell me what could be the reasons as you think?
So it could be due to post-surgical complications such as sacral nerve flex damage. That could be the reason.
Yes, yes, very good. Anything else?
UTI?
Yeah, possible. Yes, UTI. Very good. Those are the
And for some people, constipation per se can cause UTI also.
yeah, especially in the post-operative period. Yeah, I also thought the way you thought. Then uh, another thing I want to uh, tell you at this point, after the discharge, then I went through her clinical report and the post-operative management and the discharge diagnose card. From the ward, they have prescribed her analgesics and antibiotics because then after discharge, they rush to the home. They not pick the medicines from the hospital because she was so hurried to see her child actually. So she did not take any other than paracetamol. Didn't take anything. Paracetamol and some painkillers. I mean maybe according to her Brufen or something. And they have prescribed from the ward diclofenac, famotidine, and paracetamol and antibiotic. Uh, it was sorry coanoxiclave. So I asked them to continue that as well. I prescribe them diclofenac suppository in case more pain is coming instead of taking oral diclofenac and paracetamol. And I also thought that at that time it might be UFR, so I want to exclude the UFR, sorry UTI. Then I request an investigation for urine full report. So then I came expecting another update from next day with her husband. So then the next day, it is the post-operative fifth day. Her husband came again and told me condition was not improved yet. Instead of taking the analgesics and antibiotic, she's still having some mild discomfort and features of dysuria and constipation. So again, I am asking you now. This is second visit. Things still going on. So are we are we going to change our mindset? What will be going on? What would we have going on patient's condition? If you are the GP who face this problem, because yeah,
Better to do the PV.
Yeah, very good point. Yeah, there's something. Yes.
Ultrasound abdomen.
Thing is, yeah, I initially suggest them to go to hospital and recheck again, but she she very reluctant to go hospital again. Doctor, they maybe admit me again. I have to leave this child, poor child. So yeah, thank you for your contribution. So we'll go to the next slide. So I gave two options to them. First one is like you are seeing in this child slide, go to the ward. Okay, go to the ward and get inspected by doctors in the ward. Or do a UFR to exclude UTI. So this is the fifth day. So they agree to so those are the two things I left with. Then they agree to do the UFR, and the next day, that sixth day, the something happened. As you see in this slide, the next day, the day of revealing the truth. Okay. So while collecting the sample for UFR, she has noticed something unusual emerging from her private part. Okay. So now would you think what could be?
Rectovaginal fistula. Because of that, feces coming from the rectum to the vagina.
Yeah.
Vaginal pack, it maybe due post-op period they didn't remove.
Yeah, she has managed to pull it out carefully and send me this photo. Believe me, this is true photo. However, we think that those things not happen to ourselves, it is happening. It is happening. So it was a piece of surgical ghost which make her this suffering, dysuria features, constipation, and low abdominal discomfort. Luckily, she did not get any septic. It not became as a septic foci. So then, then the problem start. So I got very disappointed, and actually I missed the things, even though I ignore the basics. And whoever missed it before me, it is my duty to do.
I think we have lost Dr. Jagath for time being. He will join. Till that, we can discuss about the presentation and the issues.
So regarding this lecture,
Yes.
let's use this time to discuss something.
Yeah. Please go ahead.
So I want to ask, like now, post-surgical, don't the nurse officer in charge or the assistant medical officer in charge of the surgery, don't they count the number of gauze after the surgery?
That is a
Usually.
good point, Dr. Harun. That's a good point. That's what we learned in medical school, and when we were going into theater, what our surgeons and professors told us, they have to count.
Actually, in vaginal hysterectomy, as I know, after surgery, they insert goes back, right? But next day or after 6 hours, nursing officers should have to check for the bleeding and they have to remove.
That is the advice that they have to
Yeah.
give the patient
No,
before
not the
discharge.
patient. Before discharge, they have to do the vaginal examination and remove all the packs. After surgery, they inserted packs in the genitals wards.
So the inspection and removal is done by the nurses.
Next day, we had to, next day after surgery, either HO or the nursing officers, when they examine, they have to remove it.
usually
No,
by
the
the
patient has to
exhaustion.
be educated that the whole procedure afterwards. That is the miscommunication. Or then patient knows that things are inside. Isn't that the procedure? Education.
Normally, after VHR, they are put in the pack. Sometimes
Yes.
in the surgical the procedure, the mentioned one, it was not mentioned as that was inserted. It may be the fault, I think.
Let me contact Dr. Jagath. You can discuss. You can go on, please.
I also came across one patient and I removed the pack several years ago.
Oh my God. So
I
that
have the
the
same kind
patient,
of experience.
so the patient was never given advice that there was something like this. No proper communication, isn't it, Dr. Gopal?
Actually, what they do is it's this communication should be in the medical team. Usually, before discharge, we have to do the vaginal examination or the check.
Yeah, our
Usually,
presenter is back. Presenter is back.
Yeah, Asit, back, and then I want to share quickly my sorry about disconnection. Extremely sorry.
Yeah,
But
we were discussing. That's good. Anyway, don't worry.
right, right. It was the window for the audience discussion. I actually
Yeah, all our GPs, no, that's good points are coming in.
very good, very good. Then I will open it and share it again.
Yeah, please.
So you can keep going on your discussion.
All this experience that our GPs share in our GPs cafe, we can use them as learning points and add them to our routine mistakes. I mean, we can correct our mistakes. There are GPs who are running hospitals and mini theaters, so they can also.
Hello.
Yes, Jagat, go ahead. We can see you are trying to share.
Yeah. Um, Actually, this was
Yeah,
this
you
is the
are.
point here. Now can you see the slides?
Not the, yes, we can see it now. Yes.
All right. So here the thing is, shall I then anyone want to add anything or keep it in the end of the session?
No, we can let the audience put their points in.
Or shall I tell the things from my point and with the then
Yes,
after?
Jagat, please,
Yeah, yeah.
please go ahead.
So
Yes.
why I miss? So the things genuinely I felt in my mind. We are neighbors. Other than doctor-patient relationship, we are neighbors. We are sharing foods and we care our children also. So we are friends. So actually, I was hesitate asked about uh, regarding anything from any discomfort with your private parts and like that. And other thing is her ethnic and religious background. I know they are very hesitate to talk those things openly. Is the next point, and this is the dreadful point I uh, met into the crash. My mind was set in a preset like that means the hospital staff would have removed the vaginal practice. So even though it's a gross mistake, I at that point I did not think still it is inside vagina and the bacteria is still there. So that's the point. Whoever done the examination previously, whoever done the diagnosis. So we have to independently do our history taking, examination, and plan of management. Then after we can discuss with our colleagues. So that was the point I felt. I think. So other things. I wanted to do the abdominal examination of that patient, but she was in a hijab and uh, her body language depicted that at that time, doctor, even without examination, if you can do anything, that's okay. Like, so body language was telling me better not to examination. Like, she verbally not tell me, but with that circumstances, I would realize that at that time. So that was the then after uh, next slide. And here I mentioned some how to tackle such obstacles. So in case such a thing happen, what to do. So this is actually from our family medicine, disciplinary and teaching. Should we treat family? So should we treat family, friends, and close neighbors? So in our previously mentioned as ideally no, we should not treat, but how to handle such request? I mean, even though it has previously told better not to treat family members, friends, and close neighbors. In Sri Lanka, is a different culture. People are expecting us as a help. So in all their medical problems, in all in their medical problems, then and there. So but the actually it was very uncomfortable to keep the essence of the doctor-patient relationship in this kind of situation, friends and close neighbors. And so at that time also the procedure and examination also happened to a very limited approach to me, because I cannot request her to uh, participate for vaginal examination or abdominal examination. I know they are hesitating. Uh, if there is negative result, anything could happen, a positive result or any negative result. So I may feel bad again. So in case I need your opinion also at the end of session about treating family, friends, and family. Of course, we are doing at least friends and close neighbors. Then the next slide. So there are in our family medicine some concepts are there. We all are following this family medicine discipline. It's a patient-centered care. Yes, we know. I always respect her wish. See, I asked her to admit, but she hesitate to do because of her child. So it's in a discussion. I allow her to do it, keeping be in the home, and so. But our doctor-patient relationship is not breach anymore because I acted in the long time with them. I have doing in this relationship. So, and the other thing is continuity of care. So until the problem happening, surgery and everything, I was with her in the backup. But this thing happened, I think it could not be prevented, but it has happened. Mm, the final point is the coordinated care. Uh, that means what I want to tell you here is, if the ward people, I don't think in currently it is not practicing yet. If the ward people are at the in the diagnosis card or anything, if they are making a note to a family doctor or anyone as a routinely, I think this kind of thing would have been prevented. So here, these errors are happening everywhere, every day, today, tomorrow. This will be happening. So, to analyze this kind of error, there are some structural protocols like this. So one is the London protocol. So we are in the last two, three, four sites. I quickly finish them. And London protocol approach. So in that protocol, there are some contributing arms. So what went wrong? So what went wrong here is there is a vaginal soap retained inside. So what are the contributing factors? Actually, two contributing factors. One is system failure. System failure means actually it's towards the hospital management side. So soap count and routine checkup, maybe somewhere something has happened. And human factor, that is come to the me. So I was hesitation due to cultural sensitivity. It was the things really happen in addition to the neighborhood and this cultural problem. Okay. Uh, Asita, can you hear me?
Yes, yes.
Very good, very good. Thank you, thank you. And so finally, we have to do the preventive methods, checklist, and improve post-op review, and we have to enhance communication skills with the other professionals. I mean, not with the patient, but also with the other professionals also. So there's another protocol, another structure. So it is called duty of candor. The key principles are mentioned here as recognize the error, and if such error happen, you have to inform the patient. Patient is the one who first of all you have to inform the patient, explain the patient, and professionally you can apologize sincerely, and we have to offer and discuss with the patient solution and preventive measures. Then after, okay, then after, so yeah, we finish with the presentation, and so anything you want to add? I think you may also having such similar situations.
Jagath, did you refer back to the hospital and patient was seen by the VOG again?
Yeah, yeah. She at that it was she went to the hospital very nearby, actually DMH. She went and they have done inspection, and uh, they have then after at the ward people then send back the patient and same day. I did not give any referral letter at that time because she took the photograph and went because I think there are some lady doctors are there. I think that's why she went also. So any questions or anything you want to contribute? I am very, very welcome because this is my actually first presentation in this platform.
Yeah, that's a very nice presentation, Jagath. We can invite audience. We have little more time. Can discuss some questions and you can answer. And even if there can be some other experts in the audience, so they can also contribute, giving us. I really love that research that you have done about this London protocol and the Kando thing. Are they all surgical stuff, or we can add them? I mean,
Yeah,
they're all.
that all you can apply to even general practice.
Yeah.
That means those are very, very structured things. You never miss anything.
Yes.
Anything, and you can make your own checklist also. Because as an example, when you post-operative patient come to your clinic for an advice, you can make your checklist. Like then you may not miss anything,
Yeah.
including at least suture removal day, the day 3, how the wound is, and then post-operative fever, teacher like dysuria,
And
like
this patient was never educated about the post of care?
And no, she doesn't know. She did not know anything about that. He was
Yeah.
wondered there's something, and he took the photo and shared with me, doctor, and called me.
Yeah.
She was very alarmed at that time. Then I calmed down her.
Yes.
I didn't blame anyone. We can't blame anyone. Yeah, so okay. Then shall we? I suggest her to go to the board and get inspected because there are some lady doctors also there. Don't worry. Yeah. Then they went with the photo.
That lack of communication regarding the post discharge care, I have seen at many times. It happens with house officers, and sometimes when the patients are in a hurry to leave the ward, they don't get, sometimes they leave without the diagnosis card, and
Yes, you are correct because she actually uh, skill enough to take the diagnosed card with her, but they left the medicines in the at the hospital. They didn't take the medicine and came. So until 124 hours time, she was without any antibiotic or analgesics.
Mhm. Yeah, friends, you can add some points. Shamini, Manoj, Lianage, Supipi, friends are there, and the other MCGP batchmates of Dr. Jagath who are here. We are going to have every month GP Cafe sessions. For this January one got delayed due to some technical issues of our spice route activities. So next one will be coming soon. Jagath, can you stop sharing the
Yeah.
slides? Yeah.
Okay.
I'm going to give you a surprise.
So I want to thank, give me a little time to do that also, Dr. Asita.
Yeah, you are welcome. And Jagath, this is for you. I think you can see that.
Thank you very much.
I will be sending that to you. Can you see that?
Yes, yes, yes. I'm
Yeah,
appreciating
there is
and
yeah.
thank you very
Our
much.
president has signed, and myself as the national chair, Spice Route. So please still add to your experiences as a general practitioner who who is supporting for the development of other general practitioners as well. And we can share as a, so we can get together as GPs of every corner in Sri Lanka and have this platform of Spice Route GP Cafe to share our experience. We can give any of you a chance to present. And today we have a nice presentation from Dr. Jagath Pelandagama, a general practitioner, eminent general practitioner from Rajagiriya. He's at Kalapaluava. So he's a life member of general practitioner of College of General Practitioners Sri Lanka. That is CGPSL. And he's a young doctor. So please join our Spice Route movement. Dr. Taufik, are you there?
Yes,
Harun?
yes,
Yeah.
I'm here.
We'll be soon adding, I received your applications and all that. We'll be calling you very soon, and we'll have a short conversation, and then you all are welcome to join Spice Route.
Okay, thank you so much.
So shall we wind up for the day if there are no questions?
Yeah, Asita, 1 minute for me to give.
Yeah, Dr. Sampath Chandra Singh is asking if they are getting a participant certificate. We'll be arranging that soon because we have your registration details. We'll send, and The CPD points will be soon added to our GP Cafe's presentations. Jagath, you want to share something?
Yeah, thank you very much, everyone, Dr. Asika, Dr. Sankar, Dr. Priyanti, and everyone, and our college who making us this platform to share our thoughts and continue our education as GPs. So, and finally, thank you everyone who gathered to listen my presentation today. Good night.
Good night. And all the young doctors who has finished their MCGP or DFM, within 5 years, they are considered as young doctors. So they can also go to Wonka present conferences through in regions and in other international arenas. So what they can do is they have to present with an abstract for their case studies. Then they will be given scholarships. So next Wonka South Asia region conference is happening in Bangalore. That is in coming April. We have applied and the date is extended to February 6th. Harun, if you have something to present, we still have time to accommodate you. All others, Supipi and all other doctors in the audience. So that's a good night. Then thank you all for joining. Hope that you got something, and in the GP Cafe WhatsApp group, you can share your experience or your ideas for us to improve our presentations in the future. Thank you very much. Thank you, CGPSL, for giving us the platform and today's link. Thank you, the staff of CGPSL office.
Thank you. Good night.
Good night.
Thank you.
Good night.
Good night.